లీవ్ పర్మిట్ నాగమణిలో 12 వరకు క్లాస్
as we gather here for the workshop on the subject that lies at the very heart of the nursing care, safe delivery and essential newborn and pediatric life support. On behalf of Suyo College and Department of Nursing, I Miss Angelisa Matthews from Program Nursing Nursing. I want to welcome our esteemed guests, respected faculty members, dedicated hospital staff, and my dear fellow students. To begin this special occasion with positivity and gratitude, let us invoke blessing to the prayer song. I request Megan team for the prayer song.
Worship as we lift the holy name, serve the glory.
their life to the field of maternal and child health. I welcome Professor Nagamani.T Vlogs, Principal, CEO College of Nursing, to deliver the welcome address.
Morning, Collega. On behalf of your College of Nursing, it gives me immense pleasure to extend a warm and heartfelt welcome to each and every one of you to the hands-on simulation training program on safe delivery, essential newborn care, and pediatric life support. We are truly honored to have a distinguished group of dignitaries who have graciously accepted our invitation for today's session. It is my honor to welcome our esteemed guest and distinguished resource person for today's event, Dr. Lisa J., Principal, St. Alphonsa College of Nursing, Mysuru. Welcome to ma'am. We extend our warm welcome to Dr. S.P. Yoganasa, Chairman, CEO Group of Medical Institutions and CEO of Hospital, whose leadership and vision continues to inspire excellence in healthcare. Welcome you, sir. We are deeply grateful for the special invitees for your presence and for taking the time out of your busy schedule to grace this occasion. We are privileged to have with us Dr. R. Rajan Prasad, sir, CEMD of your Group of Medical Institutions. Welcome you, sir. We extend our warm welcome to Dr. Seema Jodanana, Vice Chairman, CEO Group of Medical Institutions and Director, CEO Hospital. Welcome you, ma'am. And a warm welcome to our esteemed resource person for the post-lunch session, Mrs. Aksa Regulus, Assistant Professor, Mr. Shashidhar, Lecturer, Sister Vedalata, Nursing Superintendent, York Hospital, Mr. Sangeeta, Lecturer. I also extend a hearty welcome to all the faculty members who have worked tirelessly behind the scenes to make this program possible. And to my dear students, the future torchbearers of nursing, whose enthusiasm and participation give life to today's session. Welcome you all. Together, let us make this program a grand success by actively learning, practicing, and spreading the importance of safe maternal and newborn care. Once again, a very warm welcome to everyone. Thank you.
Thank you, ma'am. To commence this enlightening this journey, we shall begin this auspicious lamplighting ceremony, symbolizing the displacement of darkness. Now, I invite our dignitaries on stage for the lamplighting. Thank you, everyone. Now, I would like to welcome Dr. S.P. Mogena, sir, founder and chairman of CEO Hospital and CEO Prof Medical Institution, to say a few words.
The spokesperson of the day, Dr. Isa, Principal, visitors, and my dear students and staff of our college. It gives me an extreme pleasure to be with you in this workshop. As you all know, a very important event in the human life is coming out of the womb to this world. Delivery. It's a very important event, not only for the mother, but also for the kid. This event should be ceremoniously celebrated, scientifically celebrated, and a proper care has to be given both for the mother and the kid. As you all know, the conception, the development of embryo, the pre-programmed fetal development, and delivery milestone development of the child are mysterious, highly mysterious. And we don't know who is regulating all these things. Conception will not occur for all meeting of sperms and ovum. It happens accidentally or it's not accidental, it is pre-programmed. And once this zygote is formed, what has to develop each day has been treated. Can you stop it? Can anyone stop? No, can't stop. Here's the delivery, here's the boy, maybe is matured enough to live on its own outside the womb. Everything happens minute to minute, second to second, hours to hours, days to day, months to month, in a pre-programmed. This is a highly mysterious thing in the modern medicine. Has not existed. We have all know how it is happening, why it is happening. We don't know. Who is controlling all these things? We don't know. Conception is not in our hand. Fetal development is not in the hand of either a man who produced or a woman who is harboring. Both of them have no control. Both of them do have responsible for this. Ultimately, both of them have no control. This gives a strong suspicion there is some transcendental power which is all regulating all this happening. This is one important thing that we have to say. And maternal care has reduced so many prenatal mortality and also the mother care, and it has reduced the complications of delivery, no doubt. But the modern medicine is obstructing the natural things. Nowadays, the woman doesn't want to have a natural delivery. She wants to have epidural anesthesia and have a painless delivery. And they want cesarean section, a pre-programmed cesarean section. All these things are unnatural. So therefore, this is a day where we have to introspect. Are we going against the nature? Everything going against the nature definitely is going to be detrimental in the days to come. It may give rise to so many future unpredicted evolutionary disaster which we may not know what happened. So therefore, we have to give a second thought to our new invention. No doubt, when you have an obstructed labor, when you have CDP, cephalo, pelvic, disproportion, and obstructed labor, arrested labor, you have to intervene. You have to intervene. But we have to promote a natural delivery. Mother has to feel that natural. The mother has felt 9 months of happy moments beginning in her womb. She will also feel the pleasureful, the pain, the pleasureful pain to take the cause, the pleasureful pain of passing of this fetus into this new world. So therefore, we should all think in this direction and understanding the delivery is a very important thing in the natural process. You know, the fetus, the uterus, it was of a very small size, expands during the pregnancy, not producing pain. Is it painful? The expansion of a uterus to accommodate the conception gives a pleasure to the mother. It is a pleasureful. If somebody kicks you, you get pain or pleasure. You get pain or pleasure. If somebody kicks you, what do you get? Pain or pleasure? Huh? What do you get? If somebody kicks you, what do you get? Pain. But if the baby kicks her mother from inside, does she get pain? Quickening, does it get pain? A wonderful pleasure she will get. Only the people, the women who have experienced, they will know. So what a mystery. What a mystery. If somebody kicks you from inside, outside you get pain. But the fetus will keep kicking the mother from inside. Does it produce pain? The expansion of the womb will not produce pain. In a normal, in other circumstances, if the uterus enlarges, do you get pleasure? Do you get pleasure? You get pain. But during pregnancy, during normal physiology, you get pleasure. So this will be very important thing that you should understand. And the natal care, the intra-labor care of the child, the position of the delivery, the immediate care that has to be given for the newborn, all are highly skilled and they are not the duties of the doctor nowadays. The doctor duty is to take out the baby and throw it to this world. No, it is your responsibility. The doctor sees that the baby comes out. But the responsibility of nourishing that, the responsibility of making that child to adapt to this new environment is your responsibility, nursing responsibility, paramedical responsibility. So therefore, you deserve, you need a highly skilled training. The doctor goes away. Once the baby comes out, he goes away. shouldering your responsibility. So therefore, these workshops will make you to learn the new things, the new concepts, and train you better. And I again welcome the resource persons who have come from other nursing colleges, and I wish this workshop will grow a new dimension and on the students, and also will help you to invite the new enlightening trainings in both during intrapartum and also postpartum, and also the neonatal care. I wish to workshop all this.
Thank you, sir. We extend our warm welcome to Sri Mahesh Peasal, Principal, Kaveri School of Nursing and HOD, Department of Pediatric Nursing, to this occasion. Welcome you, sir.
Good morning. Respected dignitaries on the day, after that, respected management of CEO Group of Institutions, Dr. Robert sir, and management of CEO Group of Institutions, and dynamic principal Nagamani madam, and today your senior our principal Lisa madam, all respected dear teachers and dear students. Today it's a wonderful day. We are gathered over here about the today topic, essential volunteer and more very important, essential volunteer and pediatric life support. And also very important, safe delivery at a remote labor. It's a beautiful workshop. Enjoyed very important and sincere knowledge to all of my dear students. Very important. Care your parents. Very important. And usually everybody is expected healthy baby from healthy mother. Healthy baby from healthy mother. Always to take care your parents. Very important. Why I am saying this is very important. During pregnancy period and newborn is present newborn is entirely different. When you are born is entirely different. You are born period, what are the how the your parents are, how the your mother will care, that is very important. Until your life, please take care your mother. That is the very important. Anyway, all the best for your this program. Thank you.
Thank you, sir. Very good morning. And we have come to the most important session, the morning session. I would like to introduce the resource person of morning session. So it is my honor and privilege to introduce our esteemed guest and distinguished resource person for today's event, Dr. Lisa J, Principal and Head of the Department of Optics and Gynecological Nursing at St. Alphonsa College of Nursing, Mysore. Dr. Lisa J is a highly accomplished academician, administrator and researcher in the field of nursing science with a PhD in biomedical science from Nursing Department from JSS Academy of Higher Education and Research. She brings over 2 decades of rich experience in nursing education, clinical training and research excellence. Her contribution to the field of fields are many. Dr. Lisa has served as a reviewer for more than 20 prestigious journals indexed in the Web of Science. She has actively participated in over 30 national and international conferences and seminars and successfully undertaken 3 collaboration with reputed institutions such as JSS Academy, JSS Hospital, and Philips India Limited. In recognition of her dedication and innovation, she has been honored with the Best Paper and Poster Award and has authored 28 impactful research papers in national and internationally indexed journals. Dr. Lisa has also made significant contribution as a resource person in various academic forums, presenting 8 scientific papers and 17 posters at prominent conferences. Her expertise spans obstetrics and gynecological nursing, nursing research, and advanced nursing practices, making her a role model for educators, researchers, and students alike. She is known for her innovative teaching methods, strong decision-making skills, and service-driven leadership style. We are truly privileged to have her with us today to share her wealth of knowledge and insights. Please join me in giving a warm welcome to Dr. Lisa J, our guest of day and distinguished resource person for all his efforts.
വേണ്ടേ സ്ക്രീന്
എല്ലാവരും കൂടെ ക്രോസ് ചെയ്യാൻ പറ്റും.
ഈ വയറ് ഇഞ്ചിൻ ആക്കിയിട്ട് കുറച്ച് ഫ്രീ ആയിട്ടുണ്ടാവും. ಕ್ಯಾನ್ಸಲ್ ಸರ್
ಸ್ವಲ್ಪ ಈ ಕಡೆ ಸ್ವಲ್ಪ ಹಿಂದ್ಗಡೆ ತಗೊಳಕ್ಕಾಗುತ್ತೆ ಸ್ವಲ್ಪ ಹಿಂದೆ
കുറച്ച് ಬ್ಯಾಕ್ ಅನಿಸುತ್ತೆ ಈ ವೈರ್
ಕೆಳಗಡೆ ಎಷ್ಟಾಗುತ್ತೆ ಕೆಳಗೆ
ಬ್ಯಾಕ್ ಕಾಣುವುದು ಅವ್ರದ್ದು ಕೈಬಿಡು ಅವ್ರದ್ದು ಕೈಬಿಟ್ಟು ಇದೆಲ್ಲ
you can keep down na hey you can keep down this podium here madam also can hey, you can keep ma'am
ഒരാൾക്ക് ആവശ്യമില്ല അത് വ്യക്തി എന്ന് അച്ഛൻ
Get one table outside, from outside.
So am I audible now? I start with the tax intermittent care and normal labor. So first of all, I thank the management, principal, Professor Nagamani and my friend Sangeeta for giving this opportunity. Yeah. So actually this labor, you have post stage at least 12 to 15 hours I need to complete this portion. So briefly I'm taking this class. And I more concentrate on the practical aspect. So as I said, it may take 10 to 12 hours or 12 to 15 hours to complete the labor. So I'm taking only the main part, the management only. Briefly I'm taking and I will concentrate on the mechanism and management of how to labor. So according to you people, that's some clock is very. So according to you people, whether this labor is normal process, whether it is normal process or you need hospital delivery only. According to you, what is it? Normal process or all the patients have to be, all the mothers have to admit in the hospital. Hospital. So if you ask your grandmother's mother and all whether they had undergone delivery in hospital or house or in home delivery. Home delivery. Okay. So labor is a normal process. Okay. It is a normal process. Okay. Only high risk cases we need a hospital delivery. Otherwise it's a normal process. Okay. And give you an example, my grandmother's example like I said, she has 5 children and she is only 4 feet. Okay, very short she is. Nowadays what? If the mother is short section, we will do reduced cesarean section. So that time there is no facility for cesarean and all. Then high delivery also, my grandma had undergone normal delivery, home delivery. My mother is the elder daughter and she was saying, so because when I do my MSc, I used to ask OBG, I had a specialization and I asked my mother, whether you have seen any home delivery or not. So that time she used to say, I have seen my own mother's delivery. They know that very short, my grandmother is 4 feet in home delivery. So she was saying, I was asking how she will prepare for the labor. She was saying that she knows that when the delivery pain will come, she will fetch the water because 4 children are there. So and she will prepare pickles all for 10 days, whatever she fetch water everything, and she will call the dad. Okay, so one room she will keep. She will tie one rope on that room, and she will buy and keep laying the what are the things is needed for the not so healthy. Including my mother is 75 plus. 5 also normal delivery, and you think of that she's 4 feet, there is no contracted pelvis, no CP. So labor is a normal process. 99% of the delivery is safe. Okay, and 1% it may go for the abnormal. If you have the hospital care, very good quality hospital care is there. Okay, the delivery becomes normal. So the labor is a normal process. Just you need a assist. So we cannot, whether you are posted in labor or 4 years. Normal. Okay. So you may be knowing drugs, oxytocin, methotrexate. So that time you think that they didn't have any medicine. They don't know what is oxytocin, methotrexate. So nowadays we have a good facility to prevent the complication. So most of the death will occur because of hemorrhage, sepsis, all that. To prevent that only hospital deliveries are. And still now also hilly areas, okay, and vital areas and all, home delivery is there. What is the advantages of home delivery? The infection rate is less. We compare to the hospital environment and they feel comfortable in the home. So with this introduction, I will start with my presentation. So normal labor. What is normal labor? So WHO had given the definition. So World Health Organization defines normal labor as one that is low risk throughout, spontaneous in onset, with the fetus presenting by vertex. You know all this stuff, vertex, cephalic and all. Vertex means head will be placenta. Okay. Yeah. With the mother and infant being in good condition following birth. Okay, that will call as the normal labor. Spontaneous means what? Spontaneous onset of labor. The pain will come spontaneously. You are not you are not giving any medicine. Spontaneously, the labor pain start after the 37 or 38 weeks. That we call as the normal labor. Criteria of normal labor. So, we call as a normal labor as a euthanasia. When you call as normal, when you call abnormal labor. Okay, so normal labor, so here it is given. The normal labor is filled with the following criteria. First one is spontaneous in onset and term. Term is total pregnancy, how many weeks it is? 40 weeks. Good. Okay, so 38 to 40 weeks you call as a term. So that time the spontaneous onset should be there with vertex presentation. Okay, so skull you have vertex, landmark skull, oxypole, six-pole, vertex. Okay, so that is what I will show you later. Okay, with vertex presentation, that is head should be down without undue prolongation. That means labor. Later I will show the slides. You have the duration for first stage, second stage, third stage. Beyond that, it is going because the prolongation. Then, if natural termination with minimal, if it is naturally spontaneous delivery is occurring, then without having any complication to the mother and the baby. So these are the criteria if it is critical, we can say it is a normal labor. When we call abnormal labor, okay, so dystocia, any deviation from the normal labor. So normal labor we saw what? It should be vertex presentation, it should not prolong. So these all things, and instead of that it is breech, quickly or face presentation, it's a abnormal. Deviation from the normal criteria called as the abnormal labor. Okay, so and usually labor means you should know the labor pain. Okay, labor pain, how it should be. Okay, so how it means you have true labor pain, false labor pain. Okay, sometimes you can see if you are posted in OPD, they come with back pain and abdominal pain at 30 weeks, okay, or 28 weeks. Okay, so that time we have to see whether really there is a labor pain or false labor pain. So how the labor pain is there? Usually the labor pain starts at 38 weeks or 37 weeks. Okay, the term. Painful uterine contraction at the regular interval. How it should be? The pain should be regular
contractions of the uterus you can see. Then frequency of contraction increase gradually. So when the mother comes to OPD, she will have a pain of 30 seconds. One pain remain for 30 seconds. Or 3 contraction for 10 minutes. Only 10 seconds or something. Then gradually this increase. Then it becomes 20 seconds, 30 seconds. So that's why the same frequency of contraction keep on increasing. Okay. Then intensity and duration also increase associated with the show. Okay, this is a sign of pregnancy for us a show. So I will tell you later, I have some terminologies. Then progressive effacement and dilatation of the cervix should be there. And descent of the presenting part. That is the head, that is the presenting part have to come down. Okay, so that is presenting part should descend. Then formation of bag of membrane. You have amniotic sac. You have a 4 water and 9 water. That I will show you. The bag of membrane will form. Okay, and mainly the pain won't relieve by sedation. Even usually we won't during the labor, because if you give any sedation, what happens? It may affect anesthesia and all. Okay. So if you give some, usually we give epidural dose. Okay. But with that also sometimes the pain also that is it through labor pain. So before going to the labor management, you should know the stages. Okay. How many stages are there? 4 stages of labors are there. The first stage you can see. It starts from the onset of true labor. It starts from the onset of true labor pain and ends with the full dilatation of cervix. Full dilatation of cervix means how many centimeter? 10 centimeter. Okay, 10 centimeter. So first stage you call as the cervical. So how the pain will be there means regular rhythmic contraction to the complete dilatation of cervix. You can see the mother. You touch the mother's abdomen, then there will be a hardness you feel. This hardness, how many seconds is there in your breast wash you see. So this contraction is for 30 seconds. 10 times how many contractions. So regular rhythmic contraction, and when you do the PD, cervical dilatation. Okay. How much centimeter? 10 centimeter. In the cervical dilatation, you measure it centimeter. So later I will tell you. And this first stage will be there for the primary is 12 hours and the multi is 6 hours. So you should be very careful when you write your case book. Okay. So multi means reduce your hour. Primary is 12 hours. Second stage. We start from the full dilatation of the cervix and end with the expulsion of. Second stage is what? Full dilatation, 10 centimeter dilatation to the delivery of the baby. Okay. And you have propulsive phase and expulsive phases there. Okay. And the duration you can see in the second stage, that is preemie, it takes 2 hours, that means preemie, and multi it takes 30 minutes, 30 to 45 minutes. Okay. So now you think of it. The second stage is full dilatation. Even full dilatation, after full dilatation, whether the baby will deliver immediately, why it takes 2 hours? Cervix is 10 centimeter dilated. What is the head circumference of the baby fetus? 33 centimeter. 33 to 34 centimeter. That much big head have to come, go for molding, and it happens. So the fetus have to descend down. So it will take 2 hours. Okay, 1.5 to 2 hours in the primary and 30 to 40 minutes in the multi. So this case book when you write, you have to keep in mind the stages. Third stage. Okay, now what? Second stage, baby is delivered. The third stage will start after the expulsion of the fetus and end with the expulsion of the placenta and membrane. Third stage is what? Expulsion of placenta and membrane. So once the baby is delivered, what you do? You cramp it, cut it, and give the baby for the resuscitation. Okay. Then now placenta is inside. The third stage, separation of placenta and membrane. Okay. And it takes 15 minutes for both primary and multi. What is fourth stage? It's the stage of observation. You observe the mother. It is the fourth stage of after the delivery of the placenta. The 1 hour is a crucial time. You see the condition of the mother most of the PTA chapters in this are the stage of observation. Okay. So you understood what are the stages? What is first stage? We have a pain, true labor pain. This regular rhythmic contraction to the complete dilatation of cervix. That is first stage, 10 centimeter. Second stage is full dilatation of cervix to the delivery of the expression of the fetus. That is it. Third stage is delivery of placenta and membrane. But the duration. Fourth stage is after the delivery of placenta, 1 hour stage of observation. You see the mother and baby. Okay, so usually this time you will observe the mother whether she is going for shock, the uterus is contracting, whether she is going for PTA. Okay. So once we see the terminologies, better you can understand the management and mechanism. Some of the terminology what we use. Okay, cervical dilatation. Okay, cervical dilatation. Okay, so cervical dilatation. Okay, here no cervix. Okay, so non-pregnant state, how much centimeter cervix will be dilated? Non-pregnant. Be dilated? No. Okay, the os will be closed. Okay, so you can see the cervix, the anterior lip and the posterior lips you have, it is closed. Okay, the cervix is not dilated. When it will dilate, during the labor only the cervix will dilate. Suppose you think that the cervix is dilating during that means 38 weeks, 37 weeks, what happens? It may go to the labor. The cervix is dilating with membrane rupture, it will contact to the environment and preterm labor can occur. So only during the labor the cervix will dilate. Okay. So you can see the anterior lip and posterior lip. This is the first picture you can see it is not dilated. The second picture 1 centimeter. How do you measure the dilatation of the cervix means? Like this you have introduced. One finger is 1 to 1.5 centimeter. So your two fingers you are able to put that is 3 centimeter dilatation, 4 centimeter. Okay, like this 6. Complete you are able to wide this means 10 centimeter dilatation. Okay, 10 centimeter dilatation, 10 fingers you can put inside. No, with 2 fingers only. Okay, mainly the pelvic examination with the 2 fingers. Okay, we won't have any visual aids or something. We cannot put light anything. By our finger, we will see where is the split spine. Okay, membrane is intact or rupture. Okay, hair-like structure is there. So suppose head is down, you will feel the hair-like structure. Suppose face presentation, when you put the finger, the baby will suck your finger. Suppose the buttocks is present down, reach. Your finger is staying with meconium. Okay, these and all still we find out which presentation is there. Okay, so if mouth builds, baby will suck. If the sinus builds, no, it will close. It is very sensitive. So when you know the PV, all that you have to find out. So this is 1 to 1.5 centimeter, 3 centimeter, and complete you are able to do like this, it's 10 centimeter dilatation. Okay, when you are able to do like this, you can see the cervix becomes soft. The Bishop's score is there, you can later find out. It becomes soft, okay, and you are able to do it. So complete 10 centimeter dilatation. If you understand how you measure, by centimeter with the fingers you will measure. So already I showed the criteria for the labor. Okay, how do you come to know the labor is started? One of the signs is show. Okay, so in physiological changes during pregnancy, you might be learned that a mucoid plug is formed. Here, yellow below you can see, no, there is a mucoid plug will be formed during the pregnancy. That what happened during the dilatation of the cervix, the mucoid plug will come out. Okay, that you call as a show. Okay, a mucoid plug stains with the blood is coming out because of the dilatation and effacement. You call as a show. Expression of cervical mucus plug. That means the mucus plug which is formed on the activated period, okay, pregnancy, that will come out. That is show. These all you will get in 2 months. They will ask what is show, what is cervix member, what is dilatation. Next we move on to cervical effacement. Okay, you have to keep in mind the effacement and dilatation will take place simultaneously. Okay, so this picture you can see, the first picture. You can see this is anterior lip and posterior lip. Okay, so dilatation means cervix will dilate. Effacement means the cervical lips, no, it will emerge to the lower uterine segment. That we will call as the effacement. That we will measure by the percentage. Okay, call as a taking up of cervix. Anterior lip and posterior lip will be, that lip will be emerged to the lower uterine segment. So this picture you can see. So there is no cervix. It is when you do the PV, there is no cervical lip. In second stage you can see. You see the PV, you cannot find out. Okay, OPD is gone on. When they introduce property and all, they will hold this cervix. That cervix won't be there. It will be emerged to the lower uterine segment. That is called as the taking up of cervix. So example, you will put the finger here and you will see the lips. Only half cervix is there. Call as a 3% effacement. Okay. Or sometimes when I put it, I cannot feel the lip at all. That means 100%. That means you are clear what is effacement? Taking up of cervix. The cervix will emerge to the lower uterine segment. That we call as a cervical effacement, and it is measured in percentage. Okay. Even the cervix is not effaced. Some mother we can see the cervix become hard, it is not effaced. We will take it for cesarean. One of the indications, the cervix is not ripen, you will call it the ripen. Some drugs and all they will give for the ripen. Uterine contraction. Okay. So the uterine contraction, where the uterine contraction will start. Physiological changes is not over for you. It starts from the corner of the uterus, then like a pacemaker. Fundus it will start, then it will spread over the uterus. Okay, so you can see the pain will start from here, then it will spread, full fundus will be having a pain. So you call it the neuromuscular hormone. Okay. Upper bone will contract and lower bone will dilate. Okay, upper bone will contract, lower bone will dilate. Lower bone, what happens? It aids in dilatation of cervix. Think of that lower bone, if you have contractions, what happens? The fetus descend over the obstructed labor will be there. So the uterus, the fundal dominance, the carnivore, then the pain will be dominating here and lower bone will be dilated. So you can keep the hand, you can see the firmness of the fundal. That is called as a neuromuscular hormone. Upper bone will contract, lower bone will dilate. So simultaneously effacement and dilatation will take place. Okay. And you can see the muscle fiber, the another picture, the muscle fiber of the uterus movement. The uterus will contract, retract, contract, retract. By this what? Uterus will descend down. Okay, so contract, retract means retraction means not completely relaxed. Okay, so when you check the uterine contraction, you can see the mother, there will be a hardness for the second. Again, the uterus become a little bit relaxed. That time we call the retraction. Like this, it grows, the muscle fiber size will become less and help in the descent. Okay. So you can see at the 38 weeks not it will be on the simply sternum. So and later it comes down, and during the labor because of contraction it comes down. Okay. So for the aids in the descent. Okay. So they may ask this uterine contraction and your polarity. So already I said back of membrane. Okay. So in 2 marks they may ask you what is forewater, what is hindwater. In this picture you can see the part above the girdle, that means pelvic girdle. Okay, that means above the presenting part, the amniotic fluid which is there, it calls the hindwater. Okay, below the presenting part, below the pelvic girdle, a bag of membrane is called a forewater. So this membrane will be a rupture. Okay, the head will be engaged and rupture. You can see the mother may say that the gushing of fluid. Okay, how do you differentiate it is whether it is a urine or amniotic fluid? How do you differentiate? you have to ask the mother, one thing lab test you can do, you have to ask the mother whether you are able to control whatever the fluid pass. If it is a urine, urine can be controlled, but water. If this membrane rupture means you cannot able to, the mother cannot be able to. Okay, so in case of engaged head and cold water is rupturing, no problem. If the head is not engaged, preterm at all, full fluid may go. You understood cold water and high water? Okay, so these are the terminologies you should know about the mechanism of labor. Okay, so what is line? Line refers to the relationship to the long axis of the fetus to the long axis of the uterus or spine. Okay, so normal vertex presentation, line maybe will be like this. Line is longitudinal. Okay, this is oblique. This is transverse. Even breech also, line is longitudinal. Okay, it's a relationship between the long axis of the fetus and long axis of the uterus or maternal spine. You can see the picture. Okay, so normal presentation is vertex, head is down. This is longitudinal. This is also longitudinal. This is oblique, transverse. Understood? That is line. Presentation. Okay, so when you know the mechanism, they will ask what is line, what is presentation. Here 2 marks they will ask. The part of the fetus which occupies the lower pole of the uterus. Okay. Here we can see, already said I will show you the vertex. Okay. So you know the skull. So this is two frontal bone, two parietal bone, occiput and all. Okay. This is inciput, occiput and all. Vertex is nothing but draw the imaginary line from the anterior frontal to parietal eminence posterior. This diamond shape is called as the vertex. Draw the imaginary line from the anterior frontal parietal eminence posterior from this diamond shape is called as the vertex. So what you can see, the vertex will be present down. Okay, that you call as the presentation. Okay, which part is present down this vertex? You understood what is vertex? Okay, suppose if it is bro means this is vertex. The normal flex is vertex. Okay, bro something, deflex, bro presentation. Face means like this. Okay, face will be present down. Okay. So suppose breech means buttocks will be present down. If it is oblique line, shoulder will be present down on the pelvis. Shoulder and one hand will be dangling. This is shoulder presentation. Presenting part. Okay. The presenting part is defined as the part of the presentation which overlie on the internal os. Okay. In os, what is present? That you call as. Okay. So in os, when you do the PV, you can by the figure you can find out anterior frontal to parietal eminence posterior. It is vertex. Denominator. Okay. So it is the arbitrary bony fixed point on presenting part. Okay. So example you take that the well flexed head occiput will be here. Okay. This is denominator. Okay. Then position. So position, if you want to know, you should know the landmarks of the brain. What are the 8 landmarks of the brain? If I take the time consuming, so I will fastly know. 8 landmarks of the brain is we have true pelvis consists of brain cavity and outlet, and brain you have sacropromontory, ulnar wing, sacroiliac joint, iliopetinal line, iliopetinal tendons, superior upper inner bone of the pubic bone, upper inner bone of the symphysis. So where your presenting part of the baby is there. So suppose occiput touches the iliopetinal eminence, left occipital and this is right occipital and this is left occipital. Suppose occiput is touching the sacrum, spine, you can write. Okay, so suppose the above the ischial spine is minus station, below the ischial spine is plus station. Okay, so this picture you can see. Okay, so if the head, here you can see if the presenting part is the ischial spine, 0 station, above is minus station, that is bring minus 5 station, outlet plus 5 station. What is the station? The relationship between the ischial spine. This is the ischial spine. Ischial spine and the presenting part. The presenting part may be a breech or the head, anything. Okay, it's a relationship. Okay, suppose you see that when you do the PV, okay, head is here. You say that minus 5. When you do the PV, the head is on the ischial spine, 0 station. When you do the PV, the head is on the outlet. It's plus 5 station. The next contraction, delivery of the baby will take place. See, these also words we use. What is induction of labor? Induction, augmentation. Thomas will ask you what is induction, what is augmentation. Okay. Normal spontaneous labor, how would be? You have a normal pain. Okay, the mother, because of the normal physiological process, the pain will start, the uterus will contract. Okay. So sometimes some mother, her EDD is on 38, 29, today is the age, but still now she is not getting the pain. So that time what you do, you induce the labor using the cerebral gel. Okay, vaginally you keep, and you start with 2 unit of oxytocin in 500 ml of oral. That you will call as the augmentation. No pain is there, you are inducing the labor. That will call as the augmentation. Suppose what happened, mother had a mild pain. Only 20 seconds of contraction is present. But even 2-3 hours also same contraction, deep contraction is there. That time what you do, you give 5 units of oxytocin in 500 ml of oil. That you call as the water. Induction. Okay, so that will call as the induction. Okay, augmentation and induction. Augmentation, you augment it. Okay, induction, you only are reducing the pain. So, and once the uterus is very sensitive, so as slight dose of oxytocin if you give also, it start to contract. Okay, that is induction and augmentation. Okay. So these are the terms what a nurse had done. So now I will go through the real topic, intranatal care. So intranatal care. So mainly the intranatal care start from the onset of the delivery, of the baby. What is the main aim is thorough research unit, minimal injury and readiness to deal with the complication and care of the baby. Principles, diagnosis of labor. So you have to diagnose whether it is a true labor or false labor. Monitor the progress of the labor. Measure the maternal well-being. If Sangeeta, they are not having break, all are sleeping. All of you stand up. No break there.
ബാഗ് മേടിക്കണോ?
11:30. Okay, so intranatal care, research system maternal well-being, prevention of infections, and you have to find out whether it is a normal labor or not normal. Any date is given for the mother and the baby. Any absent labor, any bleeding is there, you have to find it. So, okay, I'm not going to the physiological changes. I'm dealing with the management, how you conduct the delivery. Okay, first stage how you manage, second stage how you manage, third stage and fourth stage. This is first stage management, how you manage. So imagine first stage of management, the mother came with the labor pain. She will be on pre-labor room, antenatal ward. Then up to the 4 centimeter dilatation, she will be in pre-labor room, and after that, what she will shifted to the labor room. We call as the latent phase. Up to the 3 to 4 centimeter, mother will be in pre-labor, then will be shift to the labor. So during the first stage, that means first stage is what? Pain, regular rhythmic, contraction, true labor pain to the complete dilatation. Till that time, what you manage? Bowel preparation, usually a previous day itself, we give some laxatives to empty the bowel. Nowadays, the enema is not advised. We are not giving any. For some laxatives, we will be giving. Bladder preparation, so you see that the mother encourages the mother to empty the bladder. If she is not able to because of pain, some temporary catheter, siphons catheter, we would empty the bladder. Nutrition. Okay, here what to do in first stage, we should not give any heavy food. Okay, it is only we wet the lid with the ice cube or little water, not. What happens now? We don't know, sometimes we may take it for cesarean, sometimes failure of induction. We take it for cesarean. So that's why you should not give heavy, some idli and that and all, you don't need flying water, she dehydrate, keep it. Okay. So that don't give other foods. There is a chance she may go for cesarean. Okay, perineal shaving. So that is nowadays no perineal shaving. Okay, so when I have studied that time and all, it is very important. Okay, now because of the infection, only perineal clip we use. Then ARL, that is artificial rupture of membrane. We won't encourage. So during the spontaneously because of the dilatation of cervix, it happens. Positioning. First stage, what position we give? No positioning. They have to walk. Walk means descent of the tail. So baby will be what it will be. Example, take that baby will be on the brink. Okay. So walking may help in descent of the tail. Okay. Ask her to walk along, which is comfortable position you can do. So pain relief, usually we won't give anything. You can give some epidural analgesic which won't affect the uterine contraction. So monitor the progress of labor, you use spartograph. What is spartograph? It's a single graphical sheet. Okay. This spartograph only to use in the labor room to know the progress of the labor, mainly baby's condition, fetal condition and mother conditions will be. Okay, this is one the plotted one it is given. Uterine contraction, the dilatation, descent, fetal heart rate, mother's blood pressure, pulse, what are the drugs is given, oxytocin, buscopan, all that will be marked. Okay, so this chart will say the dilatation is progressing. Every 1 hour in the active phase, 1 centimeter dilatation. So it shows the good progress. That means what? First stage is how many hours? 12 hours. So it shows 14 hours means the progress of the labor is deteriorating. Second stage is 2 hours, but it is showing 3 hours means you have to see whether the fetal distress is there. Immediately by seeing the photograph, you take a decision for the cesarean section or forceps delivery. So photograph we use the progress of the labor. So these are the temperature, membrane, molding, dilatation, descent, contractions, okay, medications, all will be. Okay. So episotomy. What is episotomy? It's a planned incision made on the perineum and posterior vaginal. Why you do episotomy? To widen the intrauterus and to prevent the complication, you do the episotomy. It's not must that all the mother have to undergone episotomy. If it is multi and all, no need of doing. Okay, so episotomy. Next is conduction of delivery. Okay, delivery. When you conduct the delivery, you should not get hasty. So, after the post-delivery dilatation, mother will be on the labor. In conduction of the delivery, which stage it occurs? Second stage. Delivery of the head, shoulder, and front. Okay, so it should not be rapid. You should not pull the head. Okay, you have a mechanism. Movement is there. So carefully you have to deliver. Okay, so delivery of the head. Okay, delivery of the. Okay, and then you have a rotation. You have to wait for it. Delivery of the shoulder, front and shoulder. Whole body will be delivered. Delivery of the baby. So after the delivery of the baby, you will give 10 units of oxytocin intramuscularly to prophylactically prevent the PH. So after this, what you will take the baby. So the baby is delivered, cord is attached. What you do? You clamp it. You wait for 1 minute. Okay, so that will help some blood will be remaining. Okay, here you can see is till the pulsation cease, you won't cut the cord. Okay, so you can see that immediately you are cutting, what happens? Baby won't get the blood. If you wait for 1 minute and cut the cord, the baby may get 45 ml of blood. Otherwise, what it will be placenta, and placenta will be studying. So once the baby is delivered, you hand over the baby to the pediatrician. Then that is about the second stage. Third stage is management of delivery of placenta and membrane. Delivery of placenta, examination of placenta and perineum, and episodally repair. So you see how the placenta is. How much time it takes? Third stage, 10 to 15 minutes. So what are the signs of placental separation? Okay, so placenta you had cut the cord. You can see one clamp will be there, okay, hanging from the vagina. So you can see the lengthening of the cord. That means placenta is separating and coming, gushing of blood. Okay, then you can see the uterus is hard. Then laterally, what happens? The placenta will be delivered. So suppose it's not coming, you can use oxytocin. Control cord traction. You apply a massage on the mother's abdomen and downward traction and ask the mother to back up. Okay, and you can deliver. And you examine the placenta. Okay, whether placenta is complete. This is the fetal surface. This is the maternal surface. Whether all any missing contents are there. Okay, so now placenta is delivered. You will see, do the baby, any contents are there or not. Then go for the repair of the episode. Then fourth stage. What is that? Stage of observation. You observe and check. Now I will show you how we conduct the delivery. Because I didn't go very explaining the stages, because if you are browsing better, I will go for the demo.
Put on the lights, though. Lights. Anamika. 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 Good morning, Anamika. How is the session going on? All right. Then Maya, is it combined in 5 minutes? Huh? Sure?
Now I welcome Mr. Nagamani.T sir to come on and address for the festival.
ಬ್ರೇಕ್ ಮಾಡಿ ಮೇಡಮ್.
All of you take exactly 5 minutes you should come back. Otherwise, we will extend during lunch break. English government, we have
അതല്ല ഔട്ട് പോസ്റ്റ്
खाली होते ना ಇಂಟರ್ನೆಟ್
ವಾರ್ನಿಂಗ್ ಅಂತ ಬಂತು ಅದಕ್ಕೆ
ಡಾಟಾ ಯೂಸೇಜ್ ವಾರ್ನಿಂಗ್ ಅಂತ ಬಂತು ಅದಕ್ಕೆ ಇಂಟರ್ನೆಟ್ ಇದೆ ನಾವು ಇಟ್ಸ್ ವರ್ಕಿಂಗ್
ಇಲ್ಲ ಇರ್ಬೋದು ಅಂತ
ಹಾಂ
ಗಾಡಿ ಬರಲಿ
There, 32, 33, 34. Who is 34? Right, 35, 36, 35, 36, 37, 37, 38, 39, 40, 7. I send students name and parents name.
So, context of the delivery, management. So, first stage, as I said you have to bowel care, bladder care, and you have to observe the uterine contraction, fetal heart rate. The fetal heart rate, if you have tachycardia or bradycardia, it insists that baby is not stressed. Okay, the baby may pass, may fall. And baby also, you have to find out, you lubricate with the lubricant tape and you see what is the position, how much dilatation, effacement, station, you can find. Then see the mother condition and delivery is in the second stage of labor. What is second stage of labor? Delivery of the baby. So there is a full dilatation to the delivery of the baby. In that you have management of delivery of the baby and mechanism of labor, mechanism separately. Now I will show you how you conduct the delivery. So first stage of labor, ask the mother to walk. Okay, after 3-4 centimeter, let her walk the comfortable position on this bowel and bladder. Bladder if it is full of the catheter, Simon's catheter, and immediately go. You should not put phallic catheter because the bulb is there and rupture the. Then afterwards, second stage, which full dilatation is there, you know that crowning is take place. What is engagement? Here you have engagement of head. The widest transverse diameter, this biparietal diameter touches the, it comes out, it comes to the pelvis. That will be known as the engagement. The engagement is head will be fixed to the pelvis. That will occur in primary after 38 weeks. Okay, that, so before delivery itself or 38 40 weeks is the primary. But in multi, because of lacks of abdominal muscle and labda muscle, it will do in later only engagement will take place. And you see that okay, the mother will have a urge to push. Even you are not saying to push, okay, she will start to push because of the pain and because of the pelvic sense. Mother will pushing. Okay, how like she feel like deviation. So she will start pushing. So then we can say that labor is happening, and we can see the hairline structure. See, the baby's hairline structure is visible. So it says that what? Crowning takes place. So that because of good contraction, what? The head will be delivered. So, and you have to have, should not be hasty deliveries. Don't push the head very fastly, don't do it. If you do it, what happens? Once the head delivered, you don't pull. If you pull, what happens? You are moving the cord and placenta. So you may sometimes have seen the house surgeons and all they do, they will pull. Then what happens? They will get tear in the umbilical cord. So repair all that will be a problem. So don't do hasty delivery. Support the perineum. Support the perineum. You can see the hairline structure. So then you have to do the episiotomy. If it is a briny and the perineum is there, and you want to widen the intrauterus, you have to do the episiotomy. What is episiotomy? The planned surgical incision made on the perineum and posterior vagina. So now the mother is having contraction. When you have to do the episiotomy, there is a uterine contraction. Okay, you take a 5 ml of lignocaine, 1% of lignocaine, infiltrate the perineum. Okay, so infiltrate the perineum. So like this, two fingers you keep. Okay, so 5%, 5 ml of 1% lignocaine to infiltrate. Okay, then you press. See that what happens? There will be a numbness will be there. Afterwards, use the episiotomy scissor. But during contraction only you have to do it. So this is the episiotomy scissor. You put the two fingers. Okay. You can do the radiolateral episiotomy. So what happens? The introitus will have space. The head belly will be fixed. Okay. Now what episiotomy is done? Slight bleeding will be there from the episiotomy. With the next contraction, what? Delivery will take place. You can see oxygen comes under the symphysis pubis. Okay, so support it. Okay, so delivery of the head takes place. We usually like this the happens. So head will dilate by extension. So wait for the next contraction and mechanism. Okay. Then restitution take place. Okay. Delivery of the anterior shoulder. Gently you have to do it. Okay. Delivery of the posterior shoulder. Simultaneously, both the shoulders are gone. The remaining body part is gone towards the mother's abdomen. So you put it on the mother's abdomen. This is the first touch, mother and baby. So later, you wait for the clamping of the. 1 minute you wait, so the blood will go to the baby. Immediately, if you clamp like that, what happens? The blood may. So after the clamping I will show separately. So now we are clamped and cut. Okay. Hand over the baby to the pediatrician. They will do the newborn resuscitation. Okay. So immediately pre-warm towel you have to take and wipe the pediatrician. So hand over to the. So imagine the placenta is attached to the uterus. The placenta is here. So how you clamp means? Okay. So you take two artery. Even the baby is there, two artery. Okay, see the pulsation should be ceased. Okay, then using the card cutting scissor. This is a card cutting scissor. Okay, first one I have shown. This is episiotomy scissor. Take the card cutting scissor. Cut. Okay. So once the baby is separated, you want. So next is separation of the placenta. What is that? Is third stage. Okay, so third stage you have to see the separation of the placenta. What are the signs? Okay, so like this in the perineum it will be there. So like this it will be holding labor cord. You can see the lengthening of the cord. The cord length will be increasing. That means what? The placenta is coming down. The mother will bear down. Lengthening of the cord. Then you can see gushing out of blood by the separation of placenta is taking place. Okay. And uterus, if you see, it will be firm, hard, because the uterus is contracting. Okay. Then afterwards, okay, so you have a sign and you come to know that the placenta is separated to the, okay, and full placenta is delivered. Okay. And you see this placenta is 1/6 of the baby. If suppose 3 kg the baby is, it will be 500 grams. So this is a maternal surface, this is a fetal surface. And see the cord, and you have to see that two artery and one vein is there. You have to see remaining cord length. You take it from the baby and measure with the inch tape whether it is 45 to 50 centimeter. Whether it is short cord, long cord, okay, and any missing cotyledon surface. After placental examination, then you see the perineum, any perineal fat and all that is there. So 10 units of oxytocin you are given, then water. Now placenta is also delivered. You have to go there. Okay. So what I have shown you is the management. How do you conduct? Okay. So mechanism of labor means inside what are the movements are occurring. That is mechanism of labor. So that I will in slide I will briefly tell, and I will take 2 RTs and I will do the demo. You understood about the delivery? Okay. So you see in labor room how they are moving. Okay, Sangeeta madam had requested to concentrate more on mechanism for your practical exam it will be useful. So second stage of labor, you have the mechanism of labor. How do you present written demo? How do you have to do the mechanism of labor? This is I am doing for normal. Left occipital anterior. You have to start with the definition, principle, characteristic, and movement. Okay, the mechanical movement. So first is the definition of mechanism of labor. As the fetus descends, soft tissue, bony structure, exert pressure that lead to descent to the birth canal by a series of movements. Because so many movements are there. Flexion, descent, internal rotation. So these collectively, these movements we call as the mechanism of labor. Then principles. First principle is descent takes place through the labor. So you see, the baby will be high. As the labor progress, it will descend. Okay. So descent takes place through the labor. Next one is whichever part leads and first meet the resistance of the pelvic floor will rotate forward until it comes under the symphysis. Okay, so like this, okay, it comes to symphysis pubis, it will rotate 1/8 of the circles. Okay, third one is whatever emerges the pelvis will pivot on the pelvic floor. So like this, pivot. That is the third principle. Okay, so descent takes place, then whatever leads and meet the resistance of the pelvic floor will rotate forward. Whatever emerges the pelvic floor will pivot. Okay, so the characteristics. So these are the things you have to say. Line. What is line? Before break. What is line? Normal vertex presentation line is longitudinal. It's a relationship between the long axis of the fetus and long axis of the uterus or spine, maternal spine. Okay. Presentation, which is presented, satellite presentation. Then position. Okay. So you can say left occipital anterior position. Attitude. Okay. So fetal attitude, if we see, it will be very flexed. It will be in C shape. Okay. So like this, it will be there. So the attitude of the baby, normal mechanism is fully flexed. Okay. So like this, fully it will be flexed. So you have to hold like this, completely flexed. Deflexed. If you take face presentation, it is deflexed. If you take breech, compaction. Okay. So face means like this it will be. Okay. Like this it will be deflexed. Then denominator. Okay, so because of increased flexion, oxygen will become a denominator. Presenting part is okay, posterior part of the anterior corrector. So these are the characteristics we have to say. Then principal movement. Okay, descent, flexion, internal rotation of the head, extension of the head, restitution, internal rotation of the shoulder, and lateral rotation. Okay. So first we can say that engagement. So what is engagement? The largest transverse diameter will come to the pelvis. Okay. So first is engagement will take place. Okay. So movement. Okay. What first you have to say the definition. Then next is definition of principles. Okay. Then characteristics. Then the principal movement. Okay. Descent, flexion. This is the flexion. So because of increased flexion by occipital frontal become occipital, suboccipital retracting 9.5 cm. Just I will show. This is a crowning hairline structural sleeve. Delivery of the head. Okay, delivery of the shoulder. Remaining body waters. So this mechanism I will show you. So engagement will take place. What I am showing is left occipital, LOA, left occipital anterior. Occipital touches the iliopetinal eminence. What is this iliopetinal eminence? 8 points, landmarks of breath. Okay. So occipital touches the left iliopetinal eminence. Since it faces the right sacroiliac joint, the shoulder will be on the left oblique. Got it? So first is descent. We can say that descent takes place with increased flexion. Descent takes place with increased flexion. So increased flexion. So because of increased flexion, suboccipital frontal becomes suboccipital retracting 9.5 cm and occipital will take. Okay. Then next is descent and flexion. Next is internal rotation of the head. The head will rotate 1 meter of the circle from iliopetinal eminence to symphysis degrees. From the iliopetinal eminence to symphysis degrees. So what is the first principle? Descent takes place throughout the head. Second is what? Whatever part emerges the pelvic floor will rotate forward. That is the second principle. The occipital release and rotate forward. That is from the iliopetinal eminence to symphysis degrees. 1/8 of the circle. But what happens now? The shoulder will be on, shoulder won't rotate, only head will rotate 1/8 of the circle from the iliopetinal eminence to symphysis. So what happens? There will be a twist in the baby's neck. Okay. So shoulder will be on left oblique only the head will rotate 1/8 of the circle. Then next is extension of the head. Occipital fiber on the symphysis pubis. That is third principle. Whichever comes under the pubic bone will pivot on the symphysis pubis. Occiput comes under the symphysis pubis. Symphysis face and chin splits. So this time you can see the crowning. The hairline structure will be visible and head won't receive back. That will call as a crowning. So it is 3 to 4 centimeter. The head will be visible. Next is extension of head. Occiput comes under the symphysis pubis. Symphysis face and chin splits the perineum and head is formed by extension. Okay. Next is restitution. The twist made on the internal rotation of the head made by a hand-twisting movement. That we call as the restitution. When it was a twist, internal rotation, I said no, 1/8 of a circle, that time there was a twist. It is made by a hand-twisting movement. That we call as the restitution. Okay. Then further descent takes place. Okay. Then next is internal rotation of the shoulder. Where is the shoulder? It is on the left oblique. Okay. The shoulder will rotate anteriorly 1/8 of the circle from the right iliopetinal eminence to symphysis pubis. Okay. Simultaneously, external rotation of the head takes place. Okay. Further descent, the shoulder will rotate 1/8 of the circle from the iliopetinal eminence to symphysis pubis. simultaneously external rotation of the head takes place. Next is lateral flexion. So anterior shoulder comes under the synthesis pubis. Posterior shoulder sweeps the perineum. Both the shoulders are moved simultaneously. Through the lateral flexion is shown some other subdomen, the radius. See this, very repeatedly I am doing it is easy for me, but you will have to practice. Okay. So descent flexion, internal rotation of the head, extension of the head, restitution, then internal rotation of the shoulder, simultaneously external rotation of the head takes place, lateral flexion. So two volunteers will come. I will once again I will repeat the mechanism. Okay, you understood? This way you had to do the demo. Definition, principles, okay, the characteristic, main. Any doubt you have? Any doubt?
Come fast.
Ela భరవసా చేసి వర జూనియర్స్ పాపం
Sandra Cyril. Avni.
you already done the first year.
Ma'am, in this mechanism of labor, it will be helpful for your practical exam. Come fast. Cyril, come. Cyril and Shobita. Come fast.
ಇನ್ನ 803 ರೂಪಾಯಿ ಸರ್ ಇಲ್ಲೊಂದು ಸ್ಮೈಲ್ ಟೀಚರ್ ಮ್ಯಾಮ್ ನಿಮ್ಮದು ಒಂದು ಸ್ಮೈಲ್ ಕೊಡ್ತೀವಿ ಹೊಡೆದಾಯ್ತು ಲೆವೆಲ್ ಇದ್ದೀರಾ ಪ್ಲೀಸ್ ಅವರೇ ಒಬ್ರಿಬ್ರು ಬಂದ್ಬಿಟ್ಟು ಹೋದ್ರು ಇದ್ರೆ ಈ ಕಾಲೇಜ್ ಅದೇ ಇಲ್ಲಿ ಹಾಸ್ಪಿಟಲ್ ಕೆಲಸ ಮಾಡ್ತಾರಲ್ಲ ಅವರೇ ಇರ್ತಾರೆ ಯಾರು ಗೊತ್ತು ಸರ್ പിന്നെ എല്ലാവരും പറ എല്ലാവരും പറഞ്ഞു ಇದು ಸಪ್ರೇಟ್ ಇಲ್ಲ ಅವರು ಬಂದ್ಬಿಟ್ರು ಇಲ್ಲಿ ಇದೆ
ಸರಿ ಸಾಯಂಕಾಲ ಬರ್ತೀನಿ ಸಾಯಂಕಾಲ ಬರ್ತೀನಿ
They are not good for you people. Again, we are making the notes for you teaching people. If you are making notes, how to do
Just to go there, hundreds of suggestions. Just to go there, hundreds of suggestions. Yeah. Then we will get them. And break the wall. Break the extension also.
Madam, take an attendance.
ನಮ್ಗೇನು ಕ್ಲಾಸ್ ಆಗಲ್ಲ.
Certificate.
ಬೇರೆ
ವರ್ಷ ಹೇಗೆ
5-10 minutes only we finish. Hours now within 10 minutes.
They will come later, but one came and they
No ma'am. Function is important. Where ma'am? Aims. Adi medical college also there. Where we
See? See?
I'm here using the
Your anniversary special.
first after lunch, ma'am, Sangeeta ma'am will start.
Yeah, introduction also has to give.
Ma'am, first Aksa ma'am will give introduction. She will take already seen madam introduction. She will give maximum 3 to 4 minutes. She will take. After 3 to 4 minutes, Sangeeta ma'am will finish maximum within 10 minutes.
You should start with welcome dance.
Ma'am. Oh, welcome dance. Sangeeta ma'am will take maximum 10 minutes. I will take each session. I will take 5 minutes. Essentially, one get 5 minutes. Pediatrics will take 5 minutes. Maximum everything will finish within 30 minutes. After that, certificates. Madam also will just after the session. If they want the presenting in clips, they can see our
You can call them for presentation. Friends. like this before. This in past regular time.
Now,
Now, your sessions, three students are in one session.
okay.
Extend the time.
And I think students will enjoy sit funny with a lot of idea and all.
Place.
Madam. Oh, sixth, madam.
Girls, no, excuse me, girls. Last Monday. Next Monday. So we are arranging students want to yeah. Because for first she told 12:30, but again yesterday she told 6:30 she's leaving next Monday.
If boys are doing this, people are interested. Sir, what is your voice?
Healthy baby delivered. Who is best, ma'am? Boys are delivering baby rice or girls are delivering?
Have your food. Nitasha, Anamika, have your food and you can come back. Wait.
ಆಫ್ ಮಾಡ್ಬಿಡೋದಲ್ವಾ ಲೈವ್ ಪಾಸ್ ಮಾಡವ
ಒಂದು ಎಕ್ಸ್ಟ್ರಾ ಜಾಗ
ಮಾಡಿದಂಗೆ ಜಿಂದಾಗ್ತವ್ರೆ
Sandra, come here, Sandra.
A very good afternoon to everyone. I think that everyone has got this section was very beautiful and gets some knowledge, right? So thank you, Lisa ma'am, and thank you, ma'am, for being here with us. Now I welcome Lisa ma'am to give a facilitation. Welcome, ma'am.
ಸರ್ಟಿಫಿಕೇಟ್ಸ್
ಸರ್ ನೋಡಿ ಸರ್ ಸರ್ಟಿಫಿಕೇಟ್